زميلة العزيزة الدكتورة عزة عبد الحميد، أستاذ الأشعة بجامعة قناة السويس ورئيس قسم الأشعة والبيدياتريك راديولوجيست في جامعة قناة السويس. اتفضلي يا دكتورة عزة.
شكرا دكتور خالد، مساء الخير مرة تانية. هو طبعا الزملاء كلهم عرفوا نفسهم ان هم بيدياتريك راديولوجيست. انا الحقيقة يعني الأمانة تحتم عليا ان انا اقول لكم ان انا دبل ايجنت، انا عميل مزدوج، انا عضو في الويمن ايميجينج سوسايتي وكمان في البيدياتريك راديولوجي، فانا مش بيورلي بيدياتريك راديولوجيست. So I created to myself this specialty. It's little women imaging. By the end of the lecture, I hope that I can answer a couple of questions. What are the most common breast and ovarian tumors in pediatrics? And can we apply the current BI-RADS and ORADS classification systems to pediatric patients? This is the agenda. First of all, the normal ultrasound anatomy for the pediatric uterus. It's important to note that it's a matter of width rather than a length. Okay, as you can see here, this is a neonatal uterus. We should measure the epidiameter of the fundus, compare it to the epidiameter of the cervix. In a neonate, the ratio is 1 to 2. At a 7-year-old girl, the ratio epidiameter here and there, 1 to 1, and this is the adult uterus, the ratio became 2 to 1. Okay, so it's a matter of width, again, not the length. For the pediatric ovaries, we have these numbers here. Any value greater than these threshold, you should suspect an underlying mass. Okay, for the normal pediatric breast, we should be aware of the Tanner stages of development. Okay, in stage 1, okay, this is at 7-year-old, you start to see this echogenic retroareolar glandular tissue. At Tanner stage 2, this is at 10 years, it's a star-like appearance, as you can see here in a retroareolar lesion. In stage 3, you start to see this spider leg appearance representing early formation of the duct system, and by age 14 years, now we reach to the stage 4 where you can see this large retroareolar glandular tissue. At stage 5 now, this is the adult breast. So let's apply this anatomic or these anatomic data on our first case scenario, a 6-year-old female with vaginal bleeding plus left breast retroareolar lump. Okay, by looking at the uterus, you may report it as normal because you don't see any masses. And also the breast here, you don't see any masses. So you might report these as normal. But again, you should correlate that to the age. At 6 years, look at the ratios that we've talked about. This is an adult uterus, okay, 2 to 1. And in that one here, it's stage 4. So it's not concordant with the age. And by looking upwards, we can explain this by the presence of this suprarenal secreting hormone that causes precocious puberty. So be cautious about the precocious puberty. For the pediatric ovarian cysts represent 60% of all ovarian masses in the pediatric population. Okay. This is an ovarian cyst seen in a fetus. After delivery, you can see it became hemorrhagic. The length, it was 6 by 5 centimeter. Trying to locate it here with the ORADS classification, it might be located here. It's ORADS 2. But the management plan in ORADS 2, it's more than 3 centimeter, less than 10 centimeter, and the management should be follow-up. Now the question is 10 centimeter a valid cutoff value for an infant? Logic, it should not be, it should be no. So what is the appropriate cutoff value and its correlation to age then? In the literature, they gave us a 5 centimeter as a cutoff value. Below that level, you can follow up after or above that level, you go for surgery. Now let's move to ovarian tumors in children and adolescents. Germ cell tumors represent the majority of cases. And here are the histologic subtypes. Let me show you the difference. This is the first case, two different cases. The difference between immature cystic teratoma, which is malignant, with the mature cystic teratoma, which is benign. Here are the differences. The malignant form is usually large. It's about 12 to 25 centimeter, while the mature 5 to 9. Look also at the soft tissue component that does enhance after contrast in the malignant form, and look at the difference between the fat and calcification in both cases here. In immature cystic teratoma, flecks of calcifications and the tiny foci of fat, different from the gross calcification fat in the mature cystic teratoma. A complication of teratoma, what's called growing teratoma syndrome, and this is pre-surgery, the mass here. After surgery, the mass disappeared, but you can see here this fat-containing lesions in the pelvis and around the liver capsule. The syndrome incidence may be as high as 40% in children with immature teratomas. This is also another nice case. This is a dark T2 septa in a solid ovarian mass that do enhance after contrast, as you can see here. So diagnosis is this germinoma, okay? And I give it the 3 Ds, okay? To remember, this germinoma, dark septa, and elevated LDH, okay? The LDH is a tumor marker. This is also should be spot diagnosis. When you see these bright spots here, okay, the bright spots here representing the dilated enhancing vessels, typical for what? Yes, that's yolk sac tumor, bravo. 2 different cases with the same pathology. With the ultrasound, you see multilocular lesions with this solid component. With the MRI, that's very specific. Fluid levels, we give it a sponge-like mass with cystic. What's the diagnosis? Bravo, granulosa cell tumor. So tumor markers can help us in differentiating between all these tumors: alpha-fetoproteins in yolk sac tumor, immature teratoma, beta subunit in choriocarcinoma, LDH in this germinoma. Remember D with D, LDH in this germinoma, and dark septa. That's the 3rd D. CA125 in epithelial tumors, inhibin in the granulosa cell tumor. This is an 8-year-old, okay, spot diagnosis. That's the normal left ovary. Its volume was 3 cc. Compare it to the large echogenic with peripherally displaced follicles, fluid collection in the pelvis, and look at this thick pedicle diagnosis. Of course, yes, this is right adnexal torsion. For the pediatric breast masses, again, to remind you with the Tanner stages of development, this only applies for girls, not for boys, okay? You shouldn't see any of these stages in a male breast. So this was a case here, adolescent boy. You can see retroareolar glandular tissue, stage 2, but this should be diagnosed as gynecomastia in the boy. For the pediatric breast masses, most of them are benign, 70% are fibroadenomas. Cancer accounts for less than 1% of a childhood. You should remember that METS is the most common etiology for a malignant breast mass in a child. Cystosarcoma phylloides, the most common primary. Should be so cautious about requesting biopsy in a developing breast because this may damage the breast. Okay. This is CT. You can see here enhancing breast mass. It was a malignant. As I've mentioned before, METS is the most common, and the primary here was a vaginal rhabdomyosarcoma. a 6-year-old female with bilateral breast masses, rim-enhancing bilateral breast masses, okay, with you can see here diffusion restriction. Look at other lesions in the chest wall also. Okay, that was metastatic from what? What is the most? Yes, neuroblastoma is the most common primary. Malignant sarcoma of the breast. Okay, echogenic, superficially located mass with marked vascularity. That's what? This is a hemangioma, okay, typical hemangioma. Vascularity is the clue. And here is the CT of the same patient with supplying internal mammary vein. That's a nice case. I had it from one of my friends. Okay. 5-month-old baby. You can see here a tubular-like structure. We very located superficially. Cyst is not common at that age, 5 months. Okay. So we thought about the vascular malformations. We opened the Doppler, no Doppler flow, so might be slow flowing lesion. With the MRI, you can see here vascularity around the periphery of the mass. Okay, and in that here, okay, look at the arrows. They point to a venous flow. So this was a veno-lymphatic malformation. Also typical Swiss cheese appearance. When you see this in an adolescent girl, that is juvenile papillomatosis. Don't miss that. And this is an important diagnosis because despite being a benign entity, it's considered by some to be a marker for familial breast cancer, and the best management for that is surgery. This is a case of juvenile fibroadenoma. This is the classic appearance. When you see this hypoechoic cleft and echogenic, excuse me, echogenic stromal line here, this is typical, okay? And multiplicity will be suggestive. The differential diagnosis is phylloids and PASH. Although in that case it's well circumscribed, but the fast and rapid growth in a very short time with vascularity by power Doppler made it suspicious, and the pathology came with cystosarcoma phylloids. Now, can we apply BI-RADS on pediatric breast masses? The answer is no, okay? BI-RADS ultrasound categories has not been validated in pediatric and adolescent patients, and the pediatric breast procedures should not be performed solely based on BI-RADS. And in the literature, the only cutoff value given for fibroadenoma is 5 centimeter. Below that, you do follow-up. After or above that, you go for surgery. Another conservative publication, they started with 3 centimeter, not 5. Now, back to our 2 basic questions. Now we know what are the most common breast and ovarian masses in pediatrics, and does the current BI-RADS and ORADS classification systems apply to pediatric patients? The answer is no, don't apply them. And we can conclude that for pediatric breast fibroadenomas and ovarian cysts, as they are the most common lesions, 5 centimeter might be a magic number to remember for both breast and ovary. Recommendation here, it's a good point for research to develop a pediatric specific BI-RADS and ORADS classification systems that might be helpful, and thank you.
بشكر دكتورة عزة على المحاضرة الجميلة دي. هي في حاجات أسئلة بس يعني فور ماي سيلف يعني انا عندي مشكله في السايز بتاع اليوترس، هل اكتبه نورمال سايز ولا اكتبه سمول سايز اتروفايد، وخصوصا في السن اللي هو 12 13 سنه. حضرتك قلت لي اللي هو الاي بي دايمتر او الريشيو بين البودي للسيرفكس، هل ده اللي اعتمد عليه وات ايفر ذا لينس اوف ذا بودي؟
لا بص حضرتك، هو طبعا في تشارتس، في تشارتس موجوده في الليتريتشر لان احنا عمرنا ما هنحفظهم. فالتشارتس الموجوده في الليتريتشر دي زي ما قال دكتور محمد بتحط حضرتك لانه 6 سنين غير 7 سنين غير 10 سنين غير 9 سنين، ودي جالها البيريود ولا ما جالهاش البيريود، لانه برضو دي متاخره ولا مش متاخره، فهي ليها تشارتس. لكن هي الفكره في ان انت بتعرف ده ادلت من تشايلد من نيونيت من الاي بي ويدث، بتقارنهم ببعض. لكن التشارت بنعتمد على اللينث بالتشارتس.
في التشارتس اوكي. طب بالنسبه للسيست في النيونيت، حضرتك قلتي الكات اوف فاليو 5 سنتيمتر، هل اكتر من 5 حضرتك قلتي سيرجري؟ وات ايفر ذا ابييرنس اوف ذا سيست if it is unilocular thin wall clear content، برضه هعمل سيرجري حتى لو هي اكتر من 5 سم؟ هو
حسب الريفرنس، هو طبعا ما فيش كلام بالظبط مكتوب كده، بس الريفرنس اللي اتكلم كان اليوروبيان جورنال او بيدياتريك، يعني جورنال اوف بيدياتريك راديولوجي، ده بناء على ابحاث اتعملت قال انك هتعمل فولو اب لو حصل دبلنج او حصل جروث بفتره طويله او بقت كومبليكيتد جو فور سيرجري. تمام. اقل من 5 سم يو دونت، لان هو بيخاف من التورشن.
يعني بعد 5 سم برضه اعمل فولو اب ولا ما اعملش؟
لا، اكتر حسب الكلام اللي مكتوب. لو هي 5 سم وعملت لها فولو اب وطلع انكريز او مش عارف ايه او كلام كده، بتجو فور سيرجري. لو هي اكتر من 5 سم من الاول او فيها ساينز اوف كومبليكيشن جو فور سيرجري.
انا بس السؤال ده لان يعني قبل كده صادفت بيبي كان حوالي 1 مانث وفي سيست حوالي 6 7 سم، بس كانت كلير كونتنت وسين وول. انا ريكومند فولو اب وفعلا بعد شهر اختفت تماما. فده بيبقى من الاوفر ستيميليشن من الهرمونال بتاعه المذر.
هو حضرتك بعد اذن الدكتوره عزه، يعني من خبرتي مع بتوع البيدياتريك سيرجري sometimes في ناس بتفولو اب وفي ناس ممكن
بتخاف من تويست،
بتبقى ساعات يعني.
هم قالوا لي ايه رايك، فانا لازم ادلب وداني.
لا انا يعني انا شفت دايما بسيب الكلينيشن، بس انا يعني زي ما قلت لحضرتك تبقى الكلير يونيلوكولار سيست دي بشوفها كتير جدا في اطفال، وطالما انها ستيبل والحجم بتاعها ما اتغيرش. يعني في بيبي قعدنا نتابعها حوالي سنه، وبعدين لما لقيناها مش بتريزولف بعد سنه قرر انه يعمل ريسكشن.
وبتطلع سيمبل سيست على فكره. هو بيخاف من الكومبليكيشن، من التويست،
من التورشن.
بيخاف من التورشن لان بيبقى الاوفري خلاص كده ضاع لو حصل له تورشن.
السؤال الاخير، هل في طريقه افرق الفايبرو ادينوما من السيستوساركوما في اللويد؟ لانهم بيدوا نفس الابيرنس في الالترا ساوند. يعني اخرهم كانت واحده حوالي 20 سنه كانت فايبرو ادينوما وشالتها ما فيش شهر، رجعت تاني، شالتها تاني مره، رجعت تالت. هي طبعا شخصت في الاخر سيستوساركوما في اللويد. فهل فروم ذا ستارت يعني في اقدر اميزهم او افرقهم من بعضهم؟
لو كانوا شبه بعض جدا جدا زي الحاله اللي انا عرضتها، الفولو اب لان هي تكبر، يحصل لها تكبر اكتر من 30% من السايز بتاعها within short period، خلاص دي لازم احتمال جدا انها تبقى كده، او فيها هاي فاسكولاريتي، او بقى الحاجات سيستيك تشينجز حصلت فيها، ابنورماليتي في التكتشر بتاعتها، اي ساتل irregularity دي على طول تتشال. انما فعلا ساعات بيبقوا شبه بعض حتى في الكبار.
اي اوكي ثانك يو.
العفو. حتى ناسي نطقت.
Thank you, Dr. Azza, very much for this nice presentation and nice cases.